Madam, well-known consultant at Chicago. So we are very much glad to have you, madam, at our Shalakya Vidya Adhara. So I heartily welcome you, madam. Thank you, madam. Myself, Dr. Vinod Jadhav, Professor and Head, SUM Ayurvedic Medical College, Ilkal. I welcome you, madam. Thank you. And I request Dr. Santosh Pujari, sir, and Dr. Chandrakant Mudni, sir, please coordinate the session. Thank you.
Okay, thank you, sir.
Thank you, Dr. Jadhav. Thank you so much for the introduction. My name is Dr. Kulkarni. I'm doing my internal medicine residency here in Chicago in USA. I would, if you guys give me a go ahead, I can, start and then, talk a few words as well. I can share my screen and we can start. I would like you guys to give me a go ahead to start.
Okay, madam. Continue, madam.
Okay. Thank you, first of all, again, to the SVM College, respected all the principal and all the organizers of this event. It gives me a great pleasure to be sharing this podium with you all and sharing my few thoughts about headache management as you all had asked me to join. Thank you so much for this opportunity. Let me go ahead and share my screen so that we can continue the talk.
Yes, ma'am.
Okay. Please let me know if you are all able to see my screen.
Yes, ma'am. Audible and visible.
Okay, thank you. So my talk today is going to be on headache, a quick guide to diagnosis and management. Before we move forward, I would request you all, if any point during this whole talk, if you have any questions, concerns, feel free to unmute and talk, or leave your comments or questions in the chat box. I will definitely come back and answer all of your questions and concerns in the end. Thank you. So, headache is a very broad topic, but I have, tried my best to concise an approach to diagnosing a headache and most common headache disorders as well as management. Going forward, what is headache? Headache, we broadly divide headache into two main categories as primary headache and secondary headache. So here I have the list of primary headache disorders. What is a primary headache? A primary headache are due to specific headache disorders. They are most commonly seen in our practice and are usually defined by clinical criteria. They are migraine, tension type of headache, or a cluster headache, primary cough headache, exercise or exertional headache, any headache associated with sexual activity, cold stimulus headache, or primary stabbing headache, new daily persistent headache. Moving forward, headaches. In the primary headache, usually 90% of the headache we see in our clinical practice are usually these three types of headache, that is, migraine, tension type of headache, or the cluster headache. What is a migraine headache? Where it is usually located? It is usually seen in adults and it is mostly unilateral in 60 to 70% of the patients. And it can also be bifrontal or global in 30% of our patients. In children and in teenagers, that is adolescents, it can be bilateral. How is the onset of migraine? It can be gradual in onset, that is very slow in when it comes, and crescendo pattern, that is it can easily increase to a severe severity. Pulsating, some people tell headache as, oh, it is pulsating, my head is pounding. It can be very moderate to severe in intensity, and can be aggravated by routine physical activity. Coming to patient appearance, when you see a patient with severe migraine or moderate to severe migraine, they usually prefer to rest in a dark, quiet room. And how long does it last? Anywhere from 4 hours to some patients up to 3 days. What are the associated symptoms do we see with a migraine? Usually, most patients complain about nausea, vomiting, photophobia, phonophobia, and they may have an aura that is associated with any visual, sensory, or a speech or a motor disorder. These are the most common presentation of our headache, that is migraine headache. Next, coming to tension type. Where it is usually located, it is usually bilateral, that is on the both the sides of the head. And what are the common characteristics we see with the tension type? That is pressure or tightness, which waxes and wanes, that is, it comes and goes. How does the patient appear? Patient may remain active or may need to rest. That means that they can carry on their usual activities or they can rest at times as well. Tension type of headache, it can be as simple as lasting 30 minutes or in some patients up to days, as long as 7 days. And there are mostly no associated disorders or the symptoms. And coming to cluster headache, what is cluster headache? Where it is located? It is usually unilateral, that is only on the one side of your head, and usually begins around the eye or temple. And characteristics, it begins quickly and it reaches the peak or the severity within minutes, and it can be very deep, continuous, excruciating, and explosive in quality. How does the patient appear? Patient can remain active with a cluster type of headache. How long does it last? It usually doesn't last very long, the cluster type of headache, anywhere from 15 minutes to 3 hours. And associated symptoms are ipsilateral lacrimation, that is watering of the eye from one side of the eye, or redness. You can have stuffy nose, pallor, sweating, or any other neurological disorder. And some patients also complain about sensitivity to food or drinks such as alcohol or some food items as well. And one side note, cluster headache, especially in United States, it is usually seen in men, usually around the age of 20 to 40 years old. Any questions so far? And am I clearly audible to everybody?
No.
Okay, madam, it's clear.
Okay, thank you.
Clear.
Moving forward. Secondary headache types. These are the disorders of headache where you usually see headache with any other associated head and neck disorders. They are most commonly, I'm sorry, this is a very busy slide, but I've tried to highlight the most important things here. Whereas secondary headache causes can be due to a trauma or any head injury, or it can be in patients with a stroke, can be ischemic or a hemorrhagic stroke, or any other malformations, or that is the vascular malformation or aneurysm in the brain. It can be because of any thrombosis or brain neoplasms, that is any tumors, cancer of the brain, Chiari malformation, or any other birth defects. Anybody who's born with a birth defects of the brain, they can have headache. They are usually secondary because of the birth defects. Or rest of the most common causes are due to alcohol or alcohol withdrawal, caffeine withdrawal, or any other medication overuse. Headache that can be because of infection, That is when you see patients with meningitis or encephalitis, can be viral, bacterial, or fungal causes that can cause infection of the brain and lead to a severe headache, or any other conditions that can be due to disorders of the neck, eyes, ears, nose, sinus, teeth, or even mouth problems. So basically, any disorders of the head and neck organs or organ systems can lead to headache. Sometimes it can be because of psychosomatic disorders, such as any psychiatric disorder can even lead to a headache. Moving on, there are other secondary causes of headache, which are called as thunderclap headache. Why do we call them as thunderclap? Because they come within minutes and they are very, very severe. Like a thunderclap, how do you see a thunderstorm? ಅಂದ್ರೆ ಗುಡುಗು ಸಿಡಿಲು ಅಂತ ಹೇಳ್ತೀವಲ್ಲ, ಥಂಡರ್ ಕ್ಲಾಪ್. Whenever you have such severe headache, these patients present with headache of very high severity. Those headache disorders are because of usually subarachnoid or parenchymal hemorrhage. These hemorrhagic disorders, any bleeding in the brain, they can have very severe headache. Or again, cervical artery dissection, that is the arteries of your neck or the cervical. If there is any dissection, under a tear in the arteries, they can present with a severe headache. Again, ischemic or the TIA, that is the stroke. Press anta helteve, that is posterior reversible encephalopathy syndrome. Here, it is most commonly seen in a hypertensive emergency disorder. It is reversible, but whenever you see a patient with a very, very high blood pressure, they present with some changes which you see only on the imaging, that is called as reversible encephalopathy. They can have thunderclap headache as well. Subdural hematoma, again, bleed in the brain. Pituitary apoplexy, that is when your pituitary gland shrinks. Pheochromocytoma is also one of the endocrine disorders. Acute hydrocephalus, that is any fluid in the brain. Acute angle closure glaucoma. ನಿಮಗೆ ಗೊತ್ತಿರ್ಬೋದು, glaucoma is ಅದರಲ್ಲೂ acute angle closure glaucoma is the most acute condition causing a severe headache. Other primary headache disorders are primary thunderclap headache or the primary stabbing headache. So we have to always look for the signs of these thunderclap headache disorders because they can be actually life-threatening within minutes. Next, any disease, any condition, whenever you get a patient who presents to you with any problem, the key to diagnosis and management is always a good history and an exam. History andre, you have to be very thorough. They always say a good clinician or a doctor is one who obtains a very good history and an exam. So when it comes to headache, what are the history points that you should know when you get a patient with headache disorder? Let's go list by list. That is age of onset. How old, or how, at what age did that patient first have that headache episode? Next is presence or absence of any aura or a prodrome. Andre, were there any associated condition that led to a headache? Frequency, how often your patient is having that headache. Intensity, usually intensity, you can scale it on a scale of 1 to 10, how severe the headache was. Or the duration, whenever they get a headache, how long does it last? Is it minutes, hours, days? And number of headaches per month, that is number of episodes in a month, how many times? Time and mode of onset. What time of the day do you get a headache? It is very, very important. And mode, like what were they doing? How did it happen? Quality, site or radiation of the pain. Is headache, what quality? Is it throbbing? Is it pounding? So quality of the headache, actually your patients can describe it very well. In Kannada, maybe they can say tali hoditadri, or something barazdangaagate, or something like that. Then site, is it location one-sided or is it on the both the sides? Is it frontal, munde, hinde, occipital? So, or it is radiation. Does it go anywhere? Sometimes it can radiate from head to the neck, or it can be vice versa, or it can go to other parts of the body. Or associated symptoms and abnormalities. Family history, again, it is very important. I cannot emphasize how important is it to obtain a full history, so which also includes a great family history. Are any other members of the family also have similar symptoms? And next, coming, what are the precipitating and relieving factors? Like what causes them that headache and what helps them with the relieving of that headache? Exacerbation, that is what increases the headache. Or is there any relief with change in position? Like if they lay flat, andre malgidre, kutkondre, any position, change in the body position changes their intensity or frequency of their headache or just the presentation. Next is effect of activity on pain. Is there any relationship with food or alcohol? Was there any response to previous treatment? So if it is not the first time they are coming to you with a headache complaint and they previously had it, did they take any treatment for that? And did it help them in the past? Is very important to know if something that worked for them in the past. Or any recent change in vision. Has there been any vision problems or has there had any related eye disorders or vision problems? Any recent trauma, any accident or something, brain injury that is causing this headache? Also, so important is to know the lifestyle. So, has there been any changes in their sleep, exercise, weight, or diet? State of general health. So, I'm sure in Ayurveda, you all just don't focus on one problem with what your patient presents. You look at the overall picture of that patient. So, general state and general health of that patient. So you have to get to know that patient completely. So you have to know their overall state of health. Is there any change in work or lifestyle? And in women, is there any change in birth control? Is the woman on any birth control pills? Because though if they are on any oral birth control pills, they can cause headache. Or is there any association with environmental factors? Have they moved from any, is there any related to seasonal changes in their headache or something like that? And when women, again, we have to most importantly obtain the history of their menstrual cycle and any other hormonal intake and association between headache and the menstrual cycle. Next, so these are all the questions I hope that we all go through and cover in a patient who presents with a headache. Next is examination. So you have obtained a very thorough history. You have asked all the questions to your patient who comes in. Next, what are you supposed to say in the exam? I'm sorry, anybody has any questions?
No, ma'am.
Okay, moving forward, coming to examination. So what are the most important aspects of examination? Always obtain a blood pressure and a pulse of your patients. Those are the most important vital signs you have to check when you see a patient with a headache. And you have to make sure you listen for bruit. Bruit is a murmur anta ಹೇಳ್ಬೋದು that you see in neck, eyes, or in head as well. It is a clinical sign of any AV malformation. It's a very loud noise that you can easily hear on the exam. And make sure you palpate the head. Palpate and you touch and also feel for the head, neck, and shoulder regions. And checking for temporal or the neck arteries, because there are certain conditions that in the temporal region, usually in elderly, that are also associated with a headache. So you have to make sure you palpate and touch all the temporal areas and the neck regions. And never forget to examine the spine and neck muscles. A thorough neurological exam, that is mental status testing. Is your patient awake, confused, comatose? And a brief cranial nerve examination, a fundoscopy looking into the back of the eye, or an otoscopy checking on the ears, symmetry of motor reflex and the cerebellar coordination. Those are the looking for the strength, reflex, coordination, and sensation are the most important aspects of a full neurological exam. And also don't forget to do a gait exam. Gait exam is you have to walk the patient. ಹೇಗೆ ನಡೀತಾರೆ. So you have to walk them because any conditions, let's say for example, you have a huge mass or a tumor in the brain and they are affecting that part of the region, they can have problems with a gait. That is, you will easily see a patient who's unable to walk properly, or if they are moving or leaning towards one side of the body. So you have to make sure you test and do a complete neurological exam. Next, so far you have, differentiated into primary headache and secondary headache. And you know what are the most important thunderclap headache signs? That is, those are one of the dangerous signs of headache presentations. And how do we differentiate them? And we also talked about obtaining a full, complete history and examination when you get a patient with headache. And talking about low risk factors, I'm sure you will see probably, let's say, 20 patients in your practice in your day, but only 5 of them may have serious conditions and may need to be treated for a headache, who come and walk into your clinic or a hospital with a headache. So, what are the low risk factors? So, as much as it is very important to know the high risk factors, it is also important to know the low risk factors, because it can be just a general presentation to most common health problems. So in which patients you are least concerned, that is, you're not as much as worried when they come into your clinic or a hospital with this presentation. That is, anybody whose age less than or equal to 50 years, or patients who present with typical symptoms of primary headaches. Could be a migraine, cluster, or just a tension type of headache, or history of similar headache. That means they keep having same type of presentation every time. And when you do an exam, there are no abnormal neurological findings. That is, all the consciousness, motor, function, reflexes, sensation, the head and neck exam, the eye exam, they are mostly normal. And there is no concerning change in the usual headache pattern. That means they keep getting the same type of, there has been no change. And no risk for high risk comorbid conditions. Usually, a healthy young 20-year-old patient will less likely to have a serious headache problem, most likely, unless there is any other associated. So, if they don't have any other comorbid condition, like they are not immunocompromised, I mean, no history of malignancy or something like that, they are your least concerned, or no new or concerning findings on history or examination. So whenever you evaluate a patient who is less than 50, who gets similar patterns of headache, and there is no change in the presentation, and there are no high risk comorbid factors, you're less likely to be worried. So these are the patients in whom we usually do not get any imaging. That is, these patients do not require a CT or an MRI to go further and diagnose if they have any serious problem. These come under the low risk factors. Next, I came across this mnemonic in medical school, and even here in the US when I started practicing this mnemonic. Whenever I see a patient with a headache, I usually do a quick glance and as a checklist, which helps me to rule out any danger signs of headache. These are something called as the red flags. We usually, whenever, like when I talk to my senior or someone, they usually ask me, oh, are there any red flags to your patient? So if there are no red flags, then we are okay, less concerned. If there are red flags, then all of us become super, say, very, very on high alert, and we have to immediately diagnose or treat these patients. So what are those red flags? And we have to make sure to eliminate or rule out these conditions in our patients. Anybody who presents with systemic signs or symptoms, including a fever, that is, they have vital signs abnormalities, something like a high blood pressure, they have fever, altered mental status. So systemic symptoms including fever. Anybody history of with a neoplasm history, that is cancer history. ಯಾರಿಗಾದ್ರೂ ಕ್ಯಾನ್ಸರ್ ಇದ್ರೆ it is one of the red flags. Any neurological deficits on exam, that is, their conscious level is low when they come, or they're completely comatose or encephalopathic when they present to you. And if the onset is sudden or acute, they were all doing fine, but they suddenly had this headache and they presented, it is very dangerous. Older the patient, so old age, anybody above 50 years, you have to be very, very careful. A pattern change or recent onset of new headache. So is there any pattern change when they presented with this headache? Positional change, very important again. If they sit down, lay down, or get up, the headache varies. If the headache was precipitated by sneezing, coughing, or exercise, let's say a sudden cough or a sneeze precipitated this headache, then we have to be very cautious. Papilloedema, it is one of the signs that we see on the eye exam. It is the swelling of the optic disc. So if you see that on the exam, then you have to be very, very cautious in seeing this patient. Progressive headache or atypical presentation, anything that is not usual and is out of the normal, you have to be very careful. Progressive or atypical presentation, we just talked about. Coming to patients with headache in pregnancy or puerperium, that is just post-birth. In a female, when they complain of headache, extra careful. Painful eye with autonomic features, associated eye problem. Post-traumatic onset of headache after a trauma, that is any accident or something that caused the headache. Pathology of the immune system. In patients with HIV, they are completely immunocompromised. Andre avraliro immune system completely compromised agbiಟ್ಟಿರುತ್ತೆ. So in those patients, when they present with a headache, because there are usually other signs that can cause them headache in such immunocompromise, so you have to be very careful. Any painkiller or medication overuse, just patients who are on a lot of medications or who started on a new medication, or if somebody has overdosed with any medications and they come with a headache, you have to be careful. So when you see a patient with these red flags, you have to immediately do imaging of the head. It can be either CT or MRI, but you will most likely get to this bottom of the problem when you get an imaging done. So these are the patients who require immediate attention and they require imaging, either CT or MRI. So those red flags we talked about, how do they present? Because these red flag symptoms in a headache patient, they can be life-threatening. You could lose your patient within minutes. Since I'm a doctor who usually, most of my practice is based in the hospital. That is, I don't usually see patients in the clinic. I see patients in the hospital. So these are very important to me because they come to my emergency room and I'm the first person to evaluate them. So I have to address the problem right away. So when you get a patient with thunderclap headache, that is within minutes or less than few seconds, they have this explosive headache. These are the signs of underlying hemorrhage or a stroke. So it needs CT or a MRI right away, mostly CTs. when you have a patient with acute or subacute neck pain or neurological deficit, because it can be a sign of cervical artery dissection, which can cause pain in the neck or a headache, and usually it can result also in ischemic or TIA, transit, or a small stroke. Next is whenever you have a patient who is concerned for meningitis or encephalitis, that is, you have a patient with fever, altered mental status, or any signs of neurological disorders. So they are concerned for infection in your brain, can be viral, bacterial, fungal again, but meningitis or encephalitis, you have to right away do an imaging. In these patients also, lumbar puncture is the choice. Next is when you have a patient with focal neurological deficit. Um, Again, concern for increased intracranial pressure or a focal neurological deficits. So these patients are also on your high risk list. Next is patient who present with orbital or periorbital symptom, that is orbit, the area around your eye or the orbits. So because they can be concerning for acute, as common as acute angle closure glaucoma or any infection, inflammation, or tumors, any AV malformations in their orbit. So you have to assess them right away. Next is headache and possible carbon monoxide poisoning. So in the US, we also deal with a high number of patients who present with headache due to carbon monoxide poisoning. Maybe because, they go drive their cars, just stay in their cars with their being on, and they're exposed to carbon monoxide, or they are in the woods and fire and everything, and then they exposed to carbon monoxide and they present with a headache. So it can be very fatal. They can actually die. So when they come with high levels of carbon monoxides, they can also have a very severe headache. All of these patients, all the red flags and these severe presentation, they need CT or MRI. Either it can be to diagnose just what exactly is going on, or sometimes depending on the presentation, if you are suspecting with orbital signs or associated with neck dissection or cervical artery dissection or something other cause, you can also consider CT head as well as neck, face, depending on what your most common suspicion for the disease is. Next, choice of imaging. So we talked about the high risk conditions which need CT or MRI and assessment right away. Now, what is the best modality of imaging in patients who present with these symptoms? Let's go over in emergency setting. Again, when you see a patient in your emergency room, CT or MRI are the most common options, but usually, which is most readily available, cheaper, fast, and less radiation exposure is the CT. So it takes few minutes to do the CT done. So in widely practice, CT is the go-to imaging of choice. And it can easily identify any bleeding, that is hemorrhage, tumor. Sometimes can be harder to see on an MRI, but they are usually seen on the CT. So CT is the first go-to option in the emergency setting. If you're not completely clear, then you can proceed with MRI. But in 90% of the patients, CT helps you come with a diagnosis. In a non-emergent setting, so as I said earlier, most headaches are benign. Like if you see 20 patients, only 5 are the ones you are really concerned about. And not everybody needs an imaging. That is a very, very wrong concept. And especially here, a patient thinks, oh, we have a headache. What will the doctor do? They'll just go, they'll get a CT MRI. No, that's not usually the case. In a non-emergent setting, with a good history and exam, you can treat usually 90 to 95% of your patients. But something is not working, you're concerned more, then you need a thorough, further imaging as well. At that point, MRI can be obtained because you're not looking for any urgent or the emergent cause. That is something chronic and has not been treated. So you can go for MRI at that point, which gives you a detailed study of the brain. So at that point, you can get an MRI. Next, so when it comes to imaging, it is not just the CT or MRI. There are also conditions which can be diagnosed with other modalities as well. The one to go option here in the hospital setting we see is the lumbar puncture. Lumbar puncture in patients, we talked earlier about anybody who presents with fever, altered mental status, or meningeal signs. These are the cases like in cases of meningitis or encephalitis. So you have to do a lumbar puncture, so that you can obtain the CSF fluid, and then you can further do the analysis of that fluid to see if it is any viral, bacterial, or fungal infection. So lumbar puncture can be done. Where else can you do the lumbar puncture? In a condition called as normal pressure hydrocephalus. Uh, it is usually seen in older patients, this condition. We see quite a lot in my setting here, wherein in the on the imaging on the MRI, you see that there are big ventricles, and they are usually old people who have bladder incontinence and gait problems, and the imaging finding of big ventricles on the MRI. So that is normal pressure hydrocephalus. And a subarachnoid hemorrhage again. So we said that in hemorrhage, CT is the go-to finding, but sometimes when the bleed is very small, you don't see it on the CT. You have to do a CSF analysis wherein you see blood on the CSF, which is confirmation for subarachnoid hemorrhage. That's why it said subarachnoid hemorrhage in the setting of a negative or a normal head CT, but your suspicion is very high for a hemorrhage. You can go ahead and obtain a lumbar puncture where you will see the blood or the RBCs or the red blood cells in the CSF. Next, I wanted to, just touch a little bit on migraine management, since it is one of the most common conditions of headache we see in our practice. So I will just go over quickly over the management. How can you prevent, and some of the prophylaxis that you can, the medications that you can give to prevent from getting a migraine attack. What are the things you do in the acute migraine setting? That is when you get a patient with acute headache presentation. Our go-to options, what I use in my practice, are NSAIDs. These are the non-steroidal anti-inflammatory agents, that is aspirin, ibuprofen, naproxen, or combination of acetaminophen, aspirin, and diclofenac. And there are other group of medication called as the triptans. These are very specific for migraine, called as sumatriptan, rizatriptan. I'm using the generic names here. And at times, if one agent is not able to control, we can use the combination of both triptans and NSAIDs. Sometimes you have to use the other associated conditions or presentation with an acute migraine, because they usually have nausea, vomiting, auras, and whatnot. So the antiemetic, that is anti-vomiting medications, and they are usually the dopamine receptor antagonists. The dopamine receptor is a center in our brain which controls the vomiting center. So agents which act against those, they are usually chlorpromazine, flucloperazine, and metoclopramide. Next is prevention. So the other types to prevent from getting a migraine, the most common to go advice we tell our patients is the non-pharmacological measure. That is the preventative measures that help in not getting that migraine attack. So usually we ask the patients to keep a headache diary. We do that a lot in our practice. There is something called as headache diary. So we tell our patients all the history questions that I went over earlier. I give that list to my patients and tell them, hey, can you please make a headache diary like what will you be doing when you get a headache, or what time of the day, how severe it is, what helps with it, or what doesn't help with it, how long does it last. All those questions, I give them a question list and ask them to maintain a diary, so that I can identify their trigger and can tell them, advise them when they come and see me in the clinic or the hospital. So that is what is meant by trigger identification and avoidance. So when I identify that, let's say my patient, as common as I recently had a patient who was getting migraine attack due to candles, that is scented candles, the candles which emit smell. So she was lighting it in her home and she didn't realize that that was triggering her migraine. So when she kept a headache diary, she was able to correlate that lighting a candle that was scented was triggering her headache. So when we brought, when she brought that diary, we sat and talked in the clinic, and I was able to tell her, hey, can you please avoid this and see if that doesn't trigger your migraine? That actually worked. So as simple as these small techniques can be very helpful. So identifying the trigger and to avoid them are very helpful. Next is most common things that we advise is on the stress management techniques. Can be simple as relaxation therapy, or biofeedback is something which and then help them reiterate that these are the therapies that can help you to calm and relax. Studies have proven that they can also prevent them from getting a migraine. Or next is regulation of sleep patterns, intake of small frequent meals, adequate hydration. Hydration is a big key to most of our patients, and including our daily aerobic exercises in their daily routine can be extremely helpful. And someone who is in a regular work, or when you see adolescents or kids who are in schools or colleges, having a regular pattern and a regular schedule can be really important. So we tell them to maintain a good schedule and dietary habits, exercise habits. So these are the some non-pharmacological, that is no medications, but a lifestyle changes that can help in preventing from getting a migraine. Coming to prophylaxis. So these are non-pharmacological. What are the pharmacological therapies we use? So sometimes just non-pharmacological is not enough. You need help of a medication to keep from getting that headache. So it is usually required for patients who get headaches at least 5 days per month, and in some patients whom it exceeds more than 10 days per month. So those patients can be managed with medications such as propranolol, timolol. These are the beta blockers which have shown efficacy in treating the migraine. Or divalproex sodium and topiramate are usually the anti-epileptic agents which have shown help in migraine prophylaxis. So this was a small summary about migraine management. I did not get into the management of other disorders or diseases because I again would emphasize on the pharmacological, and I'm not sure that would be of much help to any of you. So did not emphasize on the medication part in management of other conditions. So as a summary, briefly, we talked about said primary headache. Oh, sorry. Primary headache and secondary headache. Primary headache is because of the condition or due to headache disorder, mainly in the brain. So I have again split them into most common and uncommon condition. Common are the tension type and the migraine headaches. Migraine headache can be without aura or with aura. And uncommon are other conditions like cluster headache, paroxysmal hemicrania, that is just one-sided, comes and goes, or a short-lasting headache attack, or primary thunderclap headache, or any trigeminal neuralgia, that is any nerve pain or a nerve disorders that can cause headache. So these are the primary headache causes. Secondary headache, or that is any disorders in the head, neck, and brain eye, that is whole includes the face as well, or any other systemic conditions that can lead to headache, that is, it is not the primary disorders of the brain. So those are most commonly mass occupying lesions. That, what do you mean by mass occupying lesion? That is a huge, any tumor or a bleed or anything like that, any lesion that occupies in one side of the brain and can lead to headache. The common are hemorrhagic. Again, there are different types of hemorrhages. And next would be tumors, either a primary brain tumor, that is any cancer, primary cancer of the brain, or metastasis, that is cancer in any other part of the body, but that has spread to the brain. So these are the mass occupying lesions, or brain abscesses, that is any infection that causes complete abscess in your brain. And other CNS pathologies, that is other central nervous system disorders, are meningitis, encephalitis, arterial dissection could be cervical or any of the arteries of the brain, or any vasoconstrictions of the blood supply of the brain, intracranial hypertension, post procedural. Some patients can have after lumbar puncture headache, or any other stroke, or after a head trauma, and other disorders external to the CNS system, that is systemic infection, URIs, upper respiratory tract infection, as simple as a cough, common cold, any sinusitis can also trigger a headache. Hypertensive emergencies, high blood pressure, which is life threatening, can cause a headache. Eye disorders, most common associated is angle closure glaucoma, vasculitis, that is inflammation of the major arteries of the head and neck. Obstructive sleep apnea, it is a condition which causes decreased blood supply, or decreased oxygen mainly to the brain during sleep. Eclampsia, preeclampsia, in pregnant patients who deal with hypertensive disorders. Carbon monoxide poisoning, substance use, alcohol, or withdrawal can cause, or any side effects to the medication can also lead to headache. So this is how we usually divide primary, secondary headache, and we went over this chart. Next. So thank you so much for being patient through the talk. I would like to give away some of the key takeaway points from my talk. What are the takeaway points that I would like you guys to keep in mind, or the overall summary from this talk? One is etiology, that is cause of the headache can vary. It can be very broad, benign to life threatening. What is benign? That is very simple, normal, um, to a life threatening, which can actually take away your life and end up in death. So those are, it can be as simple as a simple headache to life threatening. Or in all these conditions, what is the most common? Tension headache is the most common etiology or cause of the headache in your patient population. And among that, migraine headache is the most common, which the subset of patients who end up coming to the emergency department or to the clinic or the hospital. Or migraine headache can be so severe that patients most likely seek medical attention. And always remember the red flags, because those red flags, or the snoop 10, the mnemonic which I used, they are very, very important as a checklist to rule out the serious conditions of the headache. And last but not the least, neuroimaging, that is CT, MRI, or lumbar puncture, are generally not indicated in the absence of these red flags. So we can diagnose and treat without help of neuroimaging and lumbar puncture. But they're also important, but it's not that, every patient who comes to CEO has to have that imaging to diagnose and help your patients. Thank you. Now I'm open to any questions or comments. Please feel free to ask me any questions, or if there are any comments, I am more than welcome. I'm more than happy to answer.
Thank you very much, madam. Sharing your experience and well-depth knowledge regarding headache. I'm 100% sure our students will be benefited 100%. Before that question answering, one more renowned person, Dr. R.S. Sarsetti sir, joined in our group. Sir, basically from Bijapur, Karnataka, but now sir settled at Muscat. So I'm requesting Dr. R.S. Sarsetti sir, hello, to say something regarding our webinar, sir. So he is well-known personality in Karnataka, in India, as well as in abroad. So I'm requesting Dr. R.S. Sarsetti sir say something. Hello. Hello. Sir, namaste, sir. Sir. Hello. Maybe some network problem will be there. Santosh sir.
Sir.
Sir, start the question answer. If it is sir came now, we will start the discussion regarding. You guys will start. Is there any questions? Just interact with the madam, please.
Okay, sir.
Oh,
Thank you, sir.
I'm sorry. I think I did not unmute myself earlier. Oh, sorry. Is somebody speaking? I can wait.
Okay.
It's
Santosh,
okay, madam. Madam, there is one question regarding this headache only. Is there any chance to come headache in a hyper acidity condition, madam?
What exactly is hyperacidity condition?
Means gastritis.
Yeah, definitely. There have been association with acidity, and it is just one of the systemic disorder that can cause a headache. Yes, there have been association. And
okay, madam.
Moving forward, there have been previous questions in the chat box which I would like to answer. Someone asked me, please explain about photophobia and phonophobia. Photophobia and phonophobia, andre, any bright light into the eye which can cause pain. Phonophobia is any noise or any loud noise can cause ear pain. So those are the photo and the phonophobia. Next, coming back, can aspirin be given in children with migraine? It's usually not the drug of choice, but again, I am not a pediatrician and I don't deal with kids. So I don't think so aspirin would be the drug of choice in children's. Again. Next, coming to whether sweet chocolates triggers headache. Yes, it's one of the most common complaint we see in patients who relate. It's usually a sign of migraine type of headache, who relate that eating sweets, not just sweet chocolates, any sweet item or any high sugar content, and it triggers their headache. Yes, definitely. And there have been many studies done on that. There is a definite correlation. Next, I have is, what is the complication when patients suffering from brain hypoxia? So brain hypoxia, as you all know, must be decreased oxygen supply to your brain. So it can be as serious as causing or leading someone to death. There might be permanent damage to the brain, and they can never wake up again. It can lead to death, or there will be certain parts of the brain, due to hypoxia, that is decreased oxygen, and they can have lifelong side effects that, and they can have act like a stroke. So yes, those are the complications that we most commonly see. Next is there any bloodletting therapy indicated for headache? I am not sure what you mean by bloodletting therapy, uh, honestly, but I can look more into it. At this point, I'm not sure of this. Next question, is there any use of thermal cautery in migraine? Cauterization, yes, there have been studies. There is like stimulation, nerve stimulation, and other types of therapies which have really helped in migraine. Yes, cauterization, it really helps. Um, I've also had patients who have actually helped with like Botox treatments and other kinds of therapies with migraine. And certainly, I did not deal into the treatment of exact migraine parts, but yes, those are some of the therapies we have seen good effects with. Few home remedies or foods or any kinds of exercises to calm over headache. uh, as simple as it can be, as I put earlier, having a routine lifestyle, or a regular schedule in your lifestyle, and a very healthy diet and exercise involving at least 30 minutes of exercise in 5 days a week, and regular sleep and diet patterns. Those are the simple things that I can tell can overcome the headache. How to manage related to hormonal or menstrual abnormalities? This is a very good question and a very important one. So, people or women who are on hormonal therapies, we usually try to take them off because it can be one of the side effects. So, we don't put them on hormonal therapies, which can trigger the headache. We usually don't try to, because it can again lead to other side effects, clotting disorders and everything. So one thing is try not to. And with the menstrual abnormalities and causing a headache, it's a very serious association, and I think it is a multi-modality approach. When you have a woman and then menstrual disorders, it has to be involve your, a group of physicians. Like you have to have your gynecology doctor as well as your general practitioner doctor, and to come up with a plan, in how effectively we can help and manage that patient. Because also some types of biofeedback mechanism, a therapy can also help in such patients too. Regarding migraine, will it be cured permanently or no? Uh, this is a very good question, but also a tough one, because it just so varies from patient to patient, and how they present with. Yes, you can completely, I would say, prevent in the way that you can completely avoid from getting that migraine attacks. Sometimes with just pharmacological therapies or some of the medications, you can completely have the patient be migraine free lifelong. So it varies from patient to patient. Next is, why do migraine patient immobilize themselves during pounding headache attack? I think it is a class of headache that someone, wherein, because there are many triggers and environmental factors when someone is having that imminent pounding headache attack. So they usually like to isolate themselves in a dark quiet room. I think it is usually to avoid any extra other triggers or to calm themselves down. What is the first line of drug when present to ER? So whenever I see patients in my practice and then they come to the ER or the emergency department, our first go-to choice are the acetaminophen or the NSAIDs, that is uh, aspirin as well as ibuprofen, uh, naproxen. Those are the medications which I firstly try to give. And associated, if they have nausea or vomiting, we also give those medications to help calm the other side effects. Next question. If beta blockers are used for headache, does it not varies the blood pressure in non-hypertension patients? Very, very good question. I am very surprised. And then, thank you. This makes me, feel good that everybody was listening. Yes, it definitely varies blood pressure in a non-hypertensive patient. So you have to monitor that blood pressure, regularly when you administer beta blocker in a non-hypertensive patient. Not just the blood pressure, also heart rate as well, because beta blockers also lowers your heart rate. So yes, it has other antihypertensives uses as well. So you have to make sure when you give this to a non-hypertensive patient, monitor their blood pressure and if they are able to tolerate it or not, as well as the heart rate. Thank you. And thank you very much to everyone who was in this chat. And, it's been a real pleasure and interacting with all of you. As a fun fact, I was, I have lived in Ilkal until I was about 6 years old. I actually went to ACO school. So I was there until I did my LKG, UKG, and first standard there. So it gives me an immense pleasure to come back and then, talk to you guys and interact. When Dr. Pujar approached me, he actually first approached my mother, and then my mother asked me if I can, talk to all of you. It was really, I was very excited and thrilled to come and share my few thoughts. And again, thanks Dr. Pujar, and thanks to all the organizers at the SVM, Ayurvedic Medical College. This was a very, very great session. I hope the small talk has helped all of you in a small way. If not, at least the few takeaway points were helpful, and you guys will, practice in your medical career. I'm sure at least me being in allopathic medicine, at least we can share the common ground of a good exam and a history. I know that, I have gone to Ayurvedic doctors in the past. So always when I've been, they ask me a very, very good history. So that that's very impressive. So thank you again to everyone. And thank you. Any other questions?
Thank you very much, ma'am.
You're welcome.
It's happy to say that it's a very successful seminar because from beginning to end, that is full of our limit will be 100 students, ma'am. So from beginning to end, it will be 100%. So it's a very successful webinar, madam. I'm thankful for that. And some of students, they joined in YouTube Live also and Facebook Live. So I'm very much happy and thank you from my institute and from my department. Sir Santosh, sir, you want to say something?
Nothing, sir. Thanks to madam for our invitation. Thank you so much, madam. And thanks to from behalf of our all delegates and all my department and behalf of our principal, sir. Thank you so much, madam.
Yes.
Thank you.
So
Thank you very much, ma'am. Thank you, madam. Thank you.
You all have a good day. And I can, if anybody wants my slides, I can share it with Dr. Pujar. And, if any students need it in the future, they can definitely, have the reference to it. And I would be more than happy to do this in the future. So thanks for the opportunity again.
Thank you, ma'am. Thank you very much. Thank you all. Thank you.
Thank you.
Thank you so much.
Thank you. Santosh sir, end my session closed.
Okay, sir. Thanks
Thank-
to all
thank
who are presented in the session. Thank you so much. Be in touch with in the coming seminars. Thank you so much.